Hi, I'm Bradley Jacobs. I'm a suicide prevention coordinator with the VA New Jersey healthcare system. You're about to watch some clips from our VA S.A.V.E. suicide prevention gatekeeper training. VA S.A.V.E. is an acronym to help you know how to identify a veteran who could be at risk for suicide and how to respond with compassion. S.A.V.E. stands for Signs, Ask, Validate, and Encourage Treatment and Expedite Help. Signs: how do you recognize signs that someone might be having thoughts of suicide? Ask: how do you ask the most important question of all? Are you thinking of killing yourself? Are you having thoughts of suicide? V: how to validate the veteran's experience. And E, again, encouraging and expediting help. Thank you all. So yeah, we're gonna get right into it. I am a suicide prevention coordinator with the VA New Jersey healthcare system. I'll tell you a little bit about what my team does, but the focus today really is on suicide prevention. VA S.A.V.E. is a gatekeeper training. So the goal is gonna be for you to walk out of here understanding the basics in suicide prevention, how to recognize a veteran who could be at risk for suicide, could be having thoughts of suicide, and how to respond in a compassionate way to that individual and get them help. We're gonna obviously talk around suicide and about suicide, which can be a difficult topic to talk about. Most of us have our own personal experiences with suicide, whether in our personal or professional lives. So if it raises any issues, I just always like at the top of the presentation to just remind you to, you can step out at any point. I won't take offense if you need to step out. And if you need to chat a little bit afterwards, I'm happy to chat with you and make sure you've got, connections or somebody to talk to. And just remember the National Suicide Prevention Lifeline, 988 now, and the Veterans Crisis Line for any of our veterans or active duty military in the room. You can press 1 and the person who will answer is trained specifically in veterans and military issues, so they have a little bit more training than just the regular 988 folks. And we'll talk about the VCL a little bit. We're gonna talk about some basic facts around veteran suicide, some of the myths and realities. We're gonna walk through what is VA S.A.V.E., and then a whole lot of resources, of which you guys obviously are. And as I said, want you to walk out of here knowing how to identify someone at risk and how to respond to them. Explicitly, what I want to make sure is that you leave this room knowing that the expectation from us at the VA is that you get to a comfortable place talking about suicide with somebody. That in order to prevent suicide, everybody is responsible, from social workers and clinicians and healthcare providers to police and EMS drivers, but also to colleagues, neighbors, friends, getting comfortable talking about a topic that comes with a lot of stigma and shame. And this training, part of its purpose is to start to kind of rub away the edges of that stigma and make it okay to have a conversation. All right, so let's talk about some facts. I'm not gonna give a lot of data because that is an hour or two on its own. But every year, the VA publishes a suicide prevention report specific to veterans, which you can find easily. You can Google it if you just put in the National Veteran Suicide Prevention Annual Report. And that report, they actually did a double report this year, which is interesting. They kind of have one which gives you the overview and some nice graphics and stuff, and then the other one gets really detailed, takes a little more digging. And then every state has a data sheet, so you can get a little bit of information about what's happening locally in New Jersey, not just nationally. So if there's things you really have some questions about, oftentimes someone might ask me a question, and I can't remember if I'm remembering from the 2022 report or the 2024 report. So it's always good to know this and go back to it. And what I will say at the outset of talking about data, the VA, the CDC, they put out big reports. The CDC is usually a little bit ahead in terms of, because they're putting out broad population data on suicide. They will publish things about a year out, but they're preliminary findings. The VA waits about 2 years. They don't wait. They're analyzing the data, but it takes time for some of that data to filter through, and they want to make sure it gets corrected, and then they're constantly adjusting it. So you may see some slight changes in numbers and rates over time because, a local, say someone dies by suicide, the local county medical examiner is going to rule on was it a suicide or not, and that can change, right? There might be new findings later on down the road, so that there's always some slight adjustments. But one thing that, is important to state is that suicide, as much as it is a veteran issue, is a national issue. We've had since they've been tracking data, suicide rates and counts have generally increased year to year. With some dips, but overall has gone up. So it affects our whole population, adults and children, veterans, military, regular Joe Schmo from down the street, teachers. It affects every part of our population. We also know that for every suicide death, about 135 people are impacted by that suicide death. We also know, and we'll talk a little bit about risk factors, that exposure to suicide is in itself a risk factor for potential suicide, especially the closer you are to it, right? So immediate family members, we worry about when they've lost someone to suicide. We worry a little bit more about them. But, old studies used to look at just the sort of immediate family around a suicide death. Now we know that we have to look at, there's family, and then there's extended family, and then there's close friends, and then there's colleagues and neighbors. Community members could be if they go to church, right? Fellow parishioners. It could be learning about somebody in your area who died by suicide in media reporting, right? So there's a lot of effort around how this gets talked about in media. I don't know if you have noticed over the last few years, a big change whenever they do a story that involves suicide, the details are less explicit than they used to be. And then every story comes with, talking about the 988, the crisis line and what number to call and how to get support. It's never just in a vacuum anymore. And that is to make sure that conversations around suicide aren't sensationalized and don't cause any more potential risks for people. The other thing that we know is that suicide, there's not a single cause of suicide. So when we talk about suicide prevention and some of the challenges around reducing suicide rates is that it's really hard to predict. It's really hard to know who is thinking about suicide. And even if we know they're thinking about it, it's hard to know if they're going to act on it. And that's because we can't say, this one thing is the biggest thing we need to focus on when it comes to suicide prevention. There are a myriad of potential risk factors, and we're going to go through some of those things. we talk about risk factors because we want to know what those possible risk factors are, and we want to do what we can to reduce them. We also want to know what protective factors somebody has, right? So we always talk about risk and protective factors, right? Not because we all have risk factors. Every one of us in this room has risk factors when it comes to suicide. That doesn't mean that we are at, risk for suicide at this moment. But we also have lots of coping skills and strengths and protective factors. And so we want to get a full picture of somebody to help us understand how at risk they are and also how to help them. Okay, so here are some of the risk and protective factors when it comes to suicide. So under risk, we have someone who's made a prior suicide attempt, people with mental health, substance use issues, access to lethal means. I'm going to talk a little bit more about that today. Recent serious losses, legal and financial issues, relationships issues, unemployment, housing issues. Protective factors are, so someone might be diagnosed with serious depression. Sure, that's a risk factor for suicide, but maybe they go to a therapist and maybe they see a psychiatrist. Maybe they have done a lot of work and developed positive coping skills and know how to manage depressive symptoms when they get bad, right? So we want to understand what those protective factors are. Connectedness. We know a sense of belonging to a community or to something outside yourself is important and helps keep people going. A sense of spirituality. Mission and purpose. I think this is a big topic when we talk about veteran suicide prevention, especially when we talk about people transitioning out of service and back into civilian life. But that can also be, I always like to also talk broadly and extend some of this to the general population. If you think about, we'll talk a little bit about, older adults and older veterans have a lower rate of suicide than younger veterans, but die more by suicide. And part of that is that they are more likely to die in their suicide attempt. But why do we worry about older people and older veterans? Is because that loss of purpose can come, in retirement or changes in life, and their community, their family are slowly kind of diminishing. So that's really important to pay attention to. Health is huge, and we'll talk about that a little bit. So good physical health is a protective factor. It is a risk factor of having chronic health issues. And obviously employment can be a protective factor, and having good social and emotional well-being. Some risk factors particular to veterans. I highlighted a few on this list. I forgot to bring the article that this is from, but there's a link to it here, and I can always make sure to send this out to folks so you can get access to this. But this looks at, I just want to highlight a few of these. So moral injury. How many of you are familiar with the term moral injury? Okay. So not a lot of you. So it's important to look at and learn about, especially when you're working with the veteran population. Moral injury is in a very condensed nutshell, participating or bearing witness to violence or atrocities, things that go against your values as a human being, right? Your moral code. So combat veterans in particular may experience moral injury, right? This is basically a type of trauma from doing something that goes against your moral code. And and so we know there are increased rates of suicide among veterans who have experienced moral injury. A history of traumatic brain injury, military sexual trauma. So this is experiencing sexual assault or abuse, even harassment while in service. You have some handouts about that. Most suicide attempts among veterans occur following separation from service, and that first year in particular. So I talked about, that disconnect from purpose or mission is a contributing factor in that. Homeless veterans, more likely to have a suicide attempt than homeless people who are not veterans. Justice involvement is a risk factor. And then at the bottom here, veterans tend to report experiencing severe and chronic pain, more so than the non-veteran population. And we also know that chronic pain can be a risk factor for suicide. And more than half of veterans reported a chronic physical condition or mental health condition within 3 to 6 months post-separation from service. So part of this is these are all potential risk factors for veterans. Part of what I want you to pay attention to is someone who has recently transitioned out of service. That is a group that we are very concerned about. You can't see this up close, which is why I will definitely send it to you. I'll just explain what this is, and I'm going to tell you why I show it to you. So when a veteran dies by suicide and the VA becomes aware of it, part of what my team does is what we call a behavioral health autopsy. We go in and do a deep dive as much as we can into their medical record, interview providers, we talk to family, trying to understand what happened. And we send all that information into to the VA. And so this is all data from, in a 2-year window, of veterans who were receiving Veterans Healthcare Administration services, who died by suicide and did have a behavioral health autopsy data sent in. And they look at sort of what were the risk factors in the year prior to their suicide death. So things that we typically think about, hopelessness, is definitely high up here. Relationship problems, interpersonal, also high up here. But you're probably wondering, what is this purple down here where there's such a high percentage? This is health. So physical health issues. Experiencing pain in the year prior to death was the highest risk factor experience in this group of veterans who died by suicide. And sleep problems were here too. Why do I stress this so much? I was on a call yesterday with VA primary care providers. And the VA has been working over the last many years to make sure that when a veteran is seen in the VA healthcare system, every person they touch in that system understands suicide prevention is part of their job, right? So primary care doctors, nurses, social workers on that care team, this is part of your job. We have pain specialists. They actually certainly know it's part of their job. But dermatologists, the dentists, audiologists, the ophthalmologists, a lot of people don't understand, a lot of veterans come into our healthcare system and they may just go for an annual eye exam. And that's it. That's it. That's the moment that we have with that veteran. So we've been working at increasing screening. So we have our optometrists trained to do suicide screenings. And even if it's not, the screening isn't due, trained enough to say, I'm a little worried about what this person is saying. I've done the VA S.A.V.E. training. I know who the suicide prevention coordinators are. Let me talk to this veteran a little bit more. But yeah, I was on sort of having this discussion with the VA primary care providers who were like, oh, you know, yeah, we see this, but we need mental health to get involved more. And I said, of course, we need mental health to get involved more, but like, you might be the only person they talk to. And we know that physical health is a big driver of suicide attempts. Okay, protective factors specific to veterans. These are from a couple of research surveys that were done and talking to veterans about what they felt were protective factors for them. And certainly social supports post-deployment, having a greater sense of purpose and control, satisfaction with relationships, building psychological resilience, and engagement in society. Any questions about any of those risk and protective factors? Okay. So I mentioned access to lethal means in one of the risk factors. And this is a big push every year. My understanding is the VA is going to push even harder this year. But we need to talk about not just understand what are some of the risk factors and what are some of the reasons why someone attempts suicide, but we need to understand how people die by suicide. What did they actually do? And it's a bit gruesome to think about and talk about, but the purpose of it is so that if we know how someone is going to attempt suicide, we might be able to make it harder for them to use that method to kill themselves, right? So let's just look briefly at it. This is veterans in the US, adult veterans. It says 2022 because the 2024 report, the most recent data is from 2022. So 6,407 veterans died by suicide in 2022. About 41,500 US adults who are not veterans died by suicide. Again, none of this includes adolescents or children, okay? So what stands out to you from these two pie charts? Firearms, right? Both populations, high percentage of firearms used in suicide deaths. This is not attempts, this is suicide deaths. As high as it is in the non-veteran population and something we have to address, it's extremely high among the veteran population, right? So firearms are used in almost 74% of veteran suicide deaths. So just to kind of give you a zoom in on veteran suicide deaths from 2001 up to 2022. Remember I said like, it's all kind of risen over the years. When we look at the veteran population and zoom in a little bit, it's a little bumpier. So what we know is that there were, in 2021 and 2022, nearly three more people died by suicide in 2022. We had this 2-year drop where I can tell you, we were all getting really excited, like, because we saw the numbers kind of go down, and this is not rates, but we did see things going down. But if you could see the year, this is 2020, and things started to tick back up again. That could be just because it has happened before, right? We've had trends of going up and down a little bit, but it could also be that some of the advances we made were halted, and COVID played a big role in kind of throwing a giant curveball, right, at this. So let's look at some New Jersey specific data. New Jersey annually has one of the lowest rates of suicide in the country. Why do you think that might be? I don't have the exact answer, but I have an answer. Any thoughts about why New Jersey? Let me tell you a couple of the other states who have the lowest rates of suicide. New York, Connecticut. Any thoughts?
In what city?
New York City has one of the lowest rates of
I said,
suicide.
in what city?
Oh, more city, like population.
Urban.
Well, that could be. That could be. One of the highest rates of suicide is Wyoming. There's definitely a lot of space out there. Yeah, so gun laws are a big factor. We have pretty strict gun laws in New Jersey and New York. But what do you notice about this pie chart? The two pie charts. Non-veteran New Jersey adults, veteran adults in New Jersey. Anything stick out to you about suicide methods? Right? Of firearms, even with all those strict gun laws. So certainly, like compared nationally, right? Firearm deaths among non-veteran adults in New Jersey is kind of like the most is suffocation. So those gun laws are certainly potentially having an impact here. But here among the veterans in New Jersey, now granted, very low numbers. We have, not low enough, but we have much lower numbers than other states. So there's still clearly work to be done here. But we also know that even in New Jersey, veterans own firearms, are comfortable with them, know how to use them, and accessibility to that is going to make it a method used in suicide attempts. Any questions about any of that? Okay. So, as I mentioned, we want to understand the how so that we can do what we call lethal means safety, right? Lethal means safety counseling or lethal means safety checks. But this is this notion that we can reduce suicide deaths if we can make it harder for somebody to act on an impulse to kill themselves if they can't access, or we could slow down their access to their preferred method of suicide. And it's important to understand when we talk about suicide prevention that many people, most people who have thought about killing themselves have thought about how they would do it. It doesn't mean they've planned out a whole process yet, but they have thought about how they would do it, right? They've thought, well, I just look at that belt in my closet and think that that's how I would go. Or I was actually talking to a veteran whose mother had killed herself many years ago by jumping from a height. And so when he has thoughts of suicide, that's what he thinks about, right? So we want to understand that so that then we can have a conversation, and I'm going to talk about firearms first, about how do we make it so that you don't necessarily have to give up your guns, but how do we make it so you can't just grab it? So I don't know if this is true in New Jersey, but nationally, in veteran surveys, more than a third of veterans report that they keep their guns loaded and accessible, so nearby. And I've talked to many veterans in New Jersey who know exactly where the gun is in their house, even if it's not loaded with ammunition, but the ammunition's right there. They want to have access to it. So we begin a conversation about how do we create time and space? Because we know that if we can slow you down, it creates the opportunity for you to change your mind or somebody to intervene. So we're going to do a little public service announcement from the VA. I'm sorry if it's loud. Hey, you made it. Come on in.
Wait, you look so normal.
Is it loud over there in the war zone?
Are you sick of hollow gestures and meaningless nods of understanding?
Insane out there, huh?
Of civilians who think they know what you've been through?
I know you've been through.
Thank you for your services.
21! 22!
Are you tired of being repeatedly thanked and told you're a hero?
We knew we weren't going to win that one. Thank you for your service.
While you feel like a liability. Are you sick of statistics because you're so confident you'll never become one? And sucking up wounds that no one else can see? Crisis can happen unexpectedly to anyone, and though it may seem like a small barrier, a simple lock puts space between the thought and the trigger. Learn how securing your guns can help prevent suicide.
That's a powerful little commercial, right? So it speaks to this, which we brought for you to distribute out, and we can always get you more. The VA gives these away. We can give them away in volume. I'm always trying to make sure our own staff have them on hand to give out to somebody. We actually do now have a process. Someone who is registered with the VA and has a provider can get a gun lockbox. Those we don't just give out, but I can certainly, if you are working with a veteran who is registered with the VA and wants a lockbox, you can call me, or you can tell them to talk to their primary care provider about getting one. Because I send out I harass healthcare providers in the VA and remind them about this. So this is what a gun lock looks like if you're not familiar with it. Don't be shy about handing it to someone and not knowing how to use it, because I don't think I have met a veteran yet who didn't know what this is, especially if they own a gun in New Jersey and didn't know how to use it. But we also now give out these cleaning mats. Yes, they are giant mouse pads. They're basically, they feel like a giant mouse pad, but they are cleaning mats. When we first got them, I actually walked down to where the social work services office are, because one of the leads of social work service was like, I need gun locks and bring me some of those mats. And I'm walking down the hall with these mats, and one of the social workers said, "Oh, are those mouse pads?" And the other one said, "Oh, you have gun mats, I need that." Guess which one was a veteran? The veteran social worker knew exactly what this was walking down, but they have the instructions on how to use it right on here. So don't be shy about getting those. You can always reach out to me and I will get them to you in volume. So a quick little knowledge check. How many people who attempted suicide first considered it within 20 minutes of making the attempt? Anyone know that? It's not the wording is a little weird, but basically, when the person first thought about killing themselves, how many of them do you think, percentage-wise, acted on that within 20 minutes of the thought? You look like
not many.
Not many? Okay. No other guesses? No one wants to guess? 30%. Thank you for participating. All right. Is it none? A few? About half? Most? We have a few. We have 30%. All right. It's about half. Okay. Most suicide attempts, well, they're unplanned. Yes. Some are planned, but most are not. And about half reported that they made the attempt after they, within 20 minutes first thinking about it. Within an hour, it's over 70%. Okay? So a couple of things. It's a busy slide, but what we're looking at is here, right? Someone has a thought, I'm going to kill myself. Not just a thought about, I wish I were dead. But I'm done. I can't take it anymore. This is it. I want to kill myself. Nearly a quarter made the attempt within 5 minutes of that thought, almost all within an hour, but about half are within 20 minutes. So we know that suicidal crises are acute, and when they come on, people can act pretty quickly on them. The other piece of data on this slide, so these two pyramids, when a firearm is involved in a suicide attempt, it's fatal about 90% of the time. All other methods combined are fatal about 5% of the time. So what we know is when someone uses a gun, they are more likely to die in a suicide attempt. This doesn't mean we're not concerned about overdoses and strangulation, as you saw, right, or suffocation high in New Jersey. But we know that they aren't as fatal. So we do know that lethal means safety works. We do know that if someone can't use the gun right away, I've never forgotten, I first started doing this. So I'm a social worker. I've been doing this been a social worker for over 20 years. Been with the VA for 6 years. Part of the reason I came to the VA was for this job, because as a social worker and as a person who has lost family to suicide and lost clients to suicide, I was particularly interested because I always felt like, what more can I do? And the VA is a world leader in suicide prevention. But it is one of the interventions, lethal means safety, that works. It is one of the simplest thing and sort of a broad thing that anyone can do. But so if we know, as I mentioned, if we know how, we can start working with that person, right? If we know that they've thought about overdosing, or maybe they have suicidal thoughts, they haven't gotten there, but they are prescribed lots of medications that could be lethal in large doses, let's talk about medications. Most people who survive a suicide attempt don't go on to die by suicide, right? So we know if we can prevent them, we're likely not just saving their life now, but down the road. I remember where I was going. So all that experience, and I remember one of the first veterans I spoke to in this job, police officer and a veteran, and I get maybe because there was just something about him that stuck with me, but he was telling me about sitting in his car, his police vehicle, in the lot by his station with his weapon out, prepared to kill himself. And he was sitting there contemplating it when a friend called who was worried about him and called him, and a picture of his kids popped up like on his lock screen on his phone. And when he saw his kids, he changed his mind. So that quickly, he went from, I'm going to kill myself, and he had the gun in hand, to, I'm going to go get help. And he walked in, turned his weapon in, and asked his commanding officer for help. So that's how quickly we know that time really matters. Most people who are deterred from their preferred method don't seek out another method. So if they go to a bridge to jump and there are barriers and it's harder, and they eventually, as quickly as that desire to die can, generate the impulse to kill themselves, we know the reverse can happen. It can quickly get reversed, and that person isn't going to go find another way. So again, it's all about preventive. How do we work ahead? Okay, another little knowledge check. For which methods are both these statements true? Reducing access could be accomplished at home, and reducing access could save lives if routinely implemented with people at risk for suicide. They're both true, but for which method? Any thoughts?
Guns.
Guns for sure, yeah. All right, firearms and medications, right? And really, lethal means counseling, which is really just about exploring with somebody, have you had thoughts about suicide and have you thought about how you would do it? Is lethal means counseling, right? That's what starts it. And you'll be surprised, as weird of a thing as it may feel like to ask that question, you'd be surprised how willingly people will share it with you once you break through that barrier. So, important thing for you to know, as I mentioned, firearms are the most lethal and the most common cause of death in a suicide attempt, right? We know that it's true in the United States. among nearly every population, especially veterans. Medication overdose is the most common in suicide attempts. It's just that a lot less people die from medication overdoses. So I was recently working with a veteran who was suicidal, had not made an attempt, but talked about he would overdose. He was prescribed all kinds of medications. And he just leaves them, understandably, because a lot of people do this, like out on a table, because he's got to take them every day. But he's got the bottles here. He does fill a pill box. Great. So we just had a conversation of like, put all those pill bottles, keep the pill box for the week on the table. Take all those other pill bottles, put them in. Do you have another container to put them in? Sure, he's got all these kinds of little plastic containers. Put them in there, close the lid, find a closet, stick it in the back of the closet. And he did it. Does it take away the medications? Does it make it impossible for him to overdose? No. Will it slow him down? Yes. Right? Female veteran has a history of self-harm by cutting, but has also attempted by cutting. Getting sharp objects, So the conversation was, well, do you use any one particular sharp object to cut yourself? Or what have you used in suicide attempts? Unfortunately, it was a variety of things. Whatever was accessible, right? So it wasn't, there's a knife I like to use, or a particular razor, which some people have. That specific of a thought. But for her, it was anything. Okay, so I can't ask you to get rid of razors because you want to shave. I can't ask you to get rid of knives if you want to cook. But can you put them away? And don't leave knives out on the kitchen knife block, or, make sure things are in drawers. Lives with a roommate. Are you comfortable with your roommate helping you with this? Yes, the roommate she's lived with for a long time, knows she's gone through struggles, right? So it wasn't a big leap for her to talk to her roommate about, like, let's just put things away. And some things maybe I ask her to hold, so I have to go through her to get them. Okay. This is the other thing I want you to walk away from today, is that suicide is preventable, right? Like, I know I'm throwing a lot at you, and it can feel like this is a lot and a little overwhelming, but we know it's preventable. And as lethal means, safety is one very, very, very important method that we know works and prevents suicide deaths. All right, any questions to this point? No, not yet? All right. So let's talk. There's a lot of misinformation out there about suicide. I'm not going to spend a lot of time on this, but I want to walk through this with you. So one of the myths that we know is that people who talk about suicide they're just saying it to get attention. Right? Have you guys heard that before? Yeah. So maybe, but most likely not. Maybe they're asking for help. Right? Maybe they're really seriously thinking about doing it, and they need someone to stop and talk to them. And even if they're saying it in sort of an offhand, joking way, we want to make sure that they're really not serious, because we don't know. We don't know. We can't guess unless we talk about it. And someone talking about it creates an opportunity for us to intervene. Another myth: the only people who can help are mental health counselors and therapists. So we know, yes, a trained mental health provider can probably be really helpful for somebody. But when someone is experiencing a suicidal crisis or thoughts of suicide, most of us can step in and intervene at some point in that process, right? And often, I can't tell you how many people come to us after the crisis has passed. And it was like the police officer whose friend called, right? The kids jumped up and he went inside and turned in his weapon because his friend said to him, you need to stop working. You need to get rid of your gun, go inside, and I'm taking you to the hospital. Like the friend did that. We find out about it later, right? We step in at some point, but it was that friend who helped that guy through those critical moments because he trusted him, right? Sometimes that helps. I often tell the story. I worked for an organization in New York City that was for people with serious mental illness who committed a violent crime. Our waiting room could sometimes get really intense. And the receptionist I can't tell you how many times I walked out into an argument brewing, and when they saw me coming, the argument escalated. But when the head of facilities walked out and walked right up to the person, I'm sorry, can I come close? Walked to the person and went like this, hey, how you doing today? And I'm sitting there going, don't touch them, don't get close. And the guy just calmed down. He's like, let's go for a walk. They escalated because they saw me, the mental health professional, coming, because what was I gonna do? I was gonna start asserting control. I was gonna send them to the hospital, right? I was a problem. The head of facilities was not a perceived threat. He was just a regular guy. And I've been trained not to put my hands on people and not to get too close, right? The head of facility, I told him not to do that, but he doesn't listen to me because, I'm not his boss. He's going to do what he thinks is going to help. So that's not to say do that in every situation, but that kind of there's a space for people to build a connection with non-mental health providers that goes a long way. Any other myths that you've heard about suicide? That you think's not true? How about talking about suicide is going to cause someone to think that you're going to put the idea in their head? Have you heard that before? All right, don't talk about it because you're going to give someone the idea. It's just not true. We don't want to sensationalize suicide, as I talked about earlier in media, but we do know that if we broach the topic, that creates the opportunity again for someone to talk about something that otherwise we wouldn't know they were possibly thinking about. But it's a challenge because how do you know? And the only way we know is by asking. So the last myth that sometimes people say is that people just act on it. There's no really, it's a surprise. It happens without warning. And that can feel that way, right? I lost a cousin to suicide and I was shocked. But that didn't mean that there weren't signs that happened. And it's not to, I don't blame myself because I didn't see the signs. We weren't super close. But of course I said, if only I talked to him more. So it's hard. We don't talk about that too much because we don't want people to beat themselves up, but there are often signs, right? And we need to start to recognize some of those signs. So S.A.V.E. is an acronym. If you spend time working in and around the VA, we like our acronyms. S stands for signs. What are signs of suicidal thinking? A stands for asking, are you having thoughts of suicide? V, validating the veteran's experience. And E, encouraging treatment and expediting help. So as I mentioned, we're talking about, this is a gatekeeper training, right? So we want you to see the signs. We want you to talk to the person about it. We want you to validate them. And then we want you to get them to help. S.A.V.E. is what we want you to think of. So let's talk about some of the signs of suicide. I was going to put it on you, but I put the list here. How does this list look to you? Does this make sense? Right? So we look for expressions of hopelessness. Not often someone's going to walk around saying, I feel hopeless, but you never know. They might. But they may say things. What kinds of things might someone say that would make you think they're feeling hopeless? Any thoughts?
Like I have no future. Or
Huh.
something like that.
Yeah.
Or I give up.
I give up. Right? There's no point in trying anymore. I can't take it anymore. Yeah. So you look for those statements that may indicate a sense of hopelessness. Certainly increased anxiety, agitation, sleeplessness. I kind of hate that it's buried in here. When you remember the graph earlier about sleep problems, huge problem. Mood swings, intense rage or anger. We often talk about suicide as the sort of flip side to homicide, right? But increased rage or anger, risk-taking. And now this is not like, this is why it's important to, get to know people a little bit. Some people are risk takers. They're going to go bungee jumping or skydiving. That is not what we're talking about, all right? We're talking about putting themselves in danger's way intentionally or without a care, right? So going out for a few drinks and then getting in the car and driving 90 miles per hour, that's pretty risky. And plenty of people who would do that in the hopes that maybe they'll, crash. Increased drug use, alcohol use, withdrawing, a loss of purpose, right? Someone talking about, I don't really have, what's my role? I talked to this guy who had such serious medical issues that he felt both like a burden on his family and he had young daughters. He said, I'm supposed to be the caretaker. I'm the father. I'm supposed to be helping. And when we talk about, I think this is big for a lot of people. I think this is really big for veterans, right? Really big for people who believe in the warrior mentality or that I am the caretaker. And when it gets chipped away at, that's a big loss. So what's missing from that list? Someone explicitly saying things or doing things around wanting to die. Like really taking active steps. Maybe they've written a letter. Maybe they explicitly talking to you about it. And especially if they've started drinking and they're talking about it, we really want to be worried that they can act on it. And so these kinds of signs, if you see them, we're calling. Maybe we'll start with the Veterans Crisis Line. Maybe we need to call 911. Or let's go to the hospital. Can you go to the hospital? So maybe you've seen some of those signs. Maybe you're not sure, right? So we talked about this already. What's the thing to do?
Be direct with questions.
Right. Ask. Try to, in any way you can think of. You don't need to sound like a mental health counselor. Don't need to sound like a doctor. I'm going to tell you a couple of things. You can throw them out. All I care about is that you begin the conversation, right? You start the conversation with what works naturally for you. But I'm going to ask you to keep a couple of things in mind, right? Certainly ask it if you've seen any of those signs. Try not to wait. So if you're working with a client and they're saying these things, but so now you're sort of like, okay, we're done. We've spent 30 minutes doing this, and this together. And as they're walking out the door, say, oh, by the way, try to ask it right away, Let's get that conversation started as soon as possible. Try to avoid the question that sounds like you don't want them to tell you the answer, right? You're not thinking about killing yourself, are you? Now, have I asked it that way? Yes. And have I been told to just shut up and be direct by the veteran I asked that to? Yes. But we want to make sure that, we don't give them an out. Why would this give someone an out to talk about it?
Well, the instinct would be to say no.
Right.
And it's close.
Right. Now, why would they say no, though?
Because you're looking for a no.
Well, they think you're looking for a no. They think you don't care. Yeah?
It brings shame.
Shame. Would they? People will talk about it, but is it going to be the thing they want to lead a conversation with you about? No. Not necessarily. Because it's shame and stigma. What else might they be worried about? Remember the folks in the waiting area, seeing me coming? I might get in their way, but I might restrict them in some way, right? I might say, we're going to the hospital, or you're, right? I may, so it's just to be aware that when you engage in this conversation with someone who is in crisis, they're really vulnerable, and there's a lot of shame around talking about suicide. So it can get uncomfortable for them. As uncomfortable as we might feel, it can get uncomfortable for them. So we want to make sure we're direct and that we are not giving them things to support their feelings that we don't care or we don't really want to know, right? So we just want to be very careful and thoughtful moving forward at this point. Any questions about asking?
Also, setting it up for just a no answer is more like a closed-end question.
Right.
So let them, give them something.
Thank you for
They
that.
might feel more open to share.
Are you a social worker?
Yeah, I'm a licensed.
Oh, okay. That makes sense. Right. Open-ended questions are better than yes/no questions, certainly, right? But in this case, are you thinking of killing yourself is just a starting point. So it's okay, right? Part of the problem with open-ended questions this early on is that we want a direct answer, right? What have you been thinking about? Tell me a little bit about what's going on are all good conversation starters, but it doesn't get to the point, all right? So in this particular instance, we want you to be direct. We want you to start with that question. Are you thinking of killing yourself? Have you had thoughts of suicide? Two ways to start the process. You could lead with, are you thinking of hurting yourself? There's just a slight problem with that. Any thoughts about what the problem is of starting with that? Well, some people self-harm without suicidal intent, right? That cutting or bruising may bring some relief. And we want to make sure we're clear that we're talking about killing, or we're talking about suicide. Slight difference. All right, so that's the signs, the ask. Now the V is the validate. And to me, this is the most important part of SAVE. It's all important, but this is really critical. We want to make sure that we are very clear that we're there, we're taking what they're saying seriously, that there is no judgment coming from us about your thoughts of suicide. That we are going to do what we can to validate the veteran's feelings and experience in this moment. Okay? We are not condoning suicide, but we are validating that they are at the end of their rope, that they are in a lot of pain, whether it be physical or emotional pain, and they can't find another way out of that pain. And we want them to know, we understand that, we get that, and we hear that. So let's talk a moment about how we explicitly validate. All right, so someone says something like this. So you've asked the question, right? They've given you the signs, you've asked the question, you're having thoughts of suicide. And maybe they say yes or no. Maybe they say yes. Or maybe they say something like, everything is so hard, I feel like a drag on my friends. So I want you to take a second to think about what you would say in response to this. And is it validating? Is your response validating? So think about it for a second and encourage treatment and expedite help. So we want to get that person immediate help, right? That is a call 911 situation. But we want to be supportive and reassuring throughout this process. There's already shame going on, and then getting whisked off to the hospital is going to elevate that shame. So we want to do it in a supportive and safe way. There's always the option of pulling in the Veterans Crisis Line. They are a huge resource out in the community for non-clinical folks to call to immediately get someone on the phone who can begin to help and get immediate access. They are not 911. So if you already think like, I gotta get this person to the hospital, 988 is not the place to go. But if you're like, we need someone else to talk to, who do you talk to? I've got nobody, there's no one I can talk to. You can say, here's I have wallet cards, here's some Veterans Crisis Line, you know to call 988. If it gets bad later, give them a call. Or you could call them with them, right? Or you can call 988 and say, I just spoke to this person. They didn't want to talk to you yet, but can you outreach them? Veterans Crisis Line will call them. Some other things to keep in mind, right? We want to stay calm. We want to listen. It's really, I don't know about you, when I get nervous, I just start talking. So I still, to this day, I have strategies to keep myself from talking to someone in crisis. I mean, I'm talking to them, but to keep my mouth closed more than I'm talking. Because this is not a moment to be commanding or directive. This is a moment for listening. Ideally, helping them find a way through, right? To have some control through this process. Good eye contact and body language, right? We don't want to give them a reason to not trust us or think like, oh, I'm doing something to make you uncomfortable, right? We want to avoid that. Be confident. I can tell you I'm often not confident with all my years of experience, and that isn't to deter you from having a conversation. I think it's just normal. These kinds of situations can be difficult. But I don't show it. I don't show that I'm a little nervous. Right? Be supportive and then be honest. We don't want to make as hard as it might, someone like is in a fairly hopeless place looking for an answer. We don't want to promise them we have an answer because likely we don't have an immediate answer. That doesn't mean there aren't people out there who might, and there doesn't mean there aren't, there isn't help out there. But you can say, let me get you to that help. I'm going to work with you to find those people, but we want to avoid making any promises that we can't fulfill. On a phone call, similar thing, right? Keep a person on a line, try not to hang up. If you need to conference in a colleague, or a clinician if you're working with one, or the Veterans Crisis Line, do it as a conference call. Try not to let the person drop. Try and always know where a person is, right? Like on a phone call, if you don't know where they are, maybe your practice becomes starting with, we always try and start with, are you at home? Just confirming your address. Are you at work? Are you in the parking lot of ShopRite? Where are you right now? Sometimes people may not want to give it to you. They might be suspicious why you're asking. You can be honest and say, if there's any type of crisis, I want to be able to get you help if you need it. It's just part of our protocol. Or you could say something like, you know, like if you have a heart attack on the phone while I'm talking to you, I want to be able to get you help. Okay. Texting. Is it okay to text, have a text dialogue about suicide? Yeah, that's okay. I mean, a large percentage of our population texts to crisis lines, right? They do texting back and forth. You can certainly have text, just things to keep in mind, tone, right? Like, just make sure what you're writing doesn't sound flippant or dismissive, because it's so easy. You know, it's easy to do it when you're having a verbal conversation with someone, but over text, the tone can get lost. Timing is important. A lot of reflections is good, just to let the person know that you are still there on the text chain. And you can always say, why don't we get on a call together, you know, and encourage that. But it is okay. I just talked through this quite a bit about sort of gun safety. I mean, sort of lethal means safety, but always when I have, you know, we want to make sure if you have that conversation and, you know, ask about guns. Do you have guns at home? How do you store them? Here's a gun lock. You know, how do you secure them? Do you store the ammunition? Just little things to, you know, begin to weave into conversations. Rutgers, Michael and Estes has started working to build places for people to temporarily store. So one of the big obstacles to gun safety conversations is that veterans don't want their guns taken away. And when the police come to a house and it involves a mental health crisis, they're going to ask about guns. And if they find guns, they're going to secure them. You can get them back, but it's a legal process. So, you know, and then there's some legal constraints around someone, you know, like if I walk to my friend's house and I'm worried and they say, take my gun from me, well, I'll take it, but I put myself at legal risk if I am transporting a gun that I have no permit for, right? Now, you know, if I happen to get pulled over and if the police see I'm carrying a lockbox, I would say, my friend is suicidal and I'm getting the gun out of the house. You know, who knows what they would do in that point, but, you know, it is a law, so it is something to be aware of. But this is why Dr. Estes has started this process of identifying like ranges where you could pay to have your guns temporarily stored. So in a sort of like someone who's experiencing a crisis or has a history of it, why don't you put your guns there temporarily? Okay, before I get into resources, any questions? Okay, so resources. So we've talked about the Veterans Crisis Line. I will give you as much VCL swag as you want. We have the wallet cards, which are great to give to people. We have bracelets, you have chip clips, and the water bottles that we brought in before. We have magnets. I didn't bring some magnets with me. I'm almost out, but we get supplies in all the time. So if you want, you'll reach out to me. I'll get some to you. Every VA has a suicide prevention coordinator. So you guys are kind of like, you're still North Jersey, I guess. So just so you understand, right? We have the East Orange campus and the Lyons campus, and then we have about 9 community clinics sprinkled around the state. And then Wilmington and Philadelphia kind of cover the very bottom of New Jersey. But also we have like New York Harbor, Coatesville isn't far away in Pennsylvania, the Hudson Valley VA is up there. And so we have veterans in New Jersey that kind of go through all of those systems. And every one of those VAs has suicide prevention coordinators. We all overlap. We work together to make sure we cover it. Our team in New Jersey is me. Mike Kramlich is one of the case managers on the team in East Orange. Lyons, we have Ash and Rahinda. And then in Toms River, we have Heather and Meredith. You don't have to remember all this. I can get it out to you all. What we do, just very briefly, is we work within the healthcare system to identify anyone who could be at high risk for suicide. So we work with healthcare providers in the VA system. And if we think they're high risk, our case managers will get involved in sort of helping manage their care for a short window of time, usually about 3 months. We then put a flag on their medical record, and we tell veterans this. That flag pops up so that any healthcare provider nationally in the VA healthcare system will see that, hey, we're worried about this veteran. They could be at risk for suicide, and it's meant to increase access to care, and it's meant to make sure those providers check in with the veteran. So we don't want it to restrict access, and we don't want it to stigmatize, but we want to ask the dentist to say, how you doing today? Like, they don't necessarily need to ask explicitly about thoughts of suicide, but we want them to be aware we're worried about them. So pay a little attention. We come out and do community education, and then, we also have 2 people. They're called community education and partnership coordinators, Martha and Tanya, who work out in the community to create coalitions. The VA doesn't touch most veterans. Most veterans don't get their health care at the VA. So those folks are working to create coalitions in the community to help veterans get access to VA care or to get supports within their community. You can always you can Google us and you'll find us. This is a national VA sort of resource page, the Don't Wait, Reach Out. You can Google that and it should pop up for you. And it just has a lot of resources. It also, if you scroll down, has like a spread the word campaign where you can get like things to put on your emails or on your website, little video clips. They also have some powerful videos. It's a great resource page. That video, the Keep It Secure, they are telling us that this website is going to expand soon. So by September, which is Suicide Prevention Month, this is going to be have a lot of resources in it. As I mentioned, we can always get you gun locks, but this is a lot of like informational resources, brochures, things to help you have conversations with veterans around gun safety or lethal means safety, even if it's medication. But there's going to be a big push on this and improving this website. You guys have a couple of brochures in front of you. The VA creates these smartphone apps, and there's a whole bunch of them. I'm going to talk about the safety plan app. I think I brought one for the insomnia app too. But these are great apps. The mindfulness app is like a meditation app. It's free. It's free for anyone. It's not just for veterans. It's a really these are like really well designed. I can't speak highly enough about them. They're quite impressive. The safety plan app is one of them. Do you guys do safety plans, suicide prevention safety plans? Social workers? So I'm happy to have a follow-up conversations about safety plans. It's not part of the SAVE training, but the app is a great resource. So anyone that has thoughts of suicide, I really recommend safety planning with them. There's a model of doing safety plans that the VA follows from Barbara Stanley. Basically, a safety plan, I'll just very briefly, it's a 6-step veteran-guided plan as to how do I recognize if I'm experiencing a mental health crisis and how do I keep myself safe. And the 6 steps are sort of identifying your triggers and warning signs. What are my coping strategies that I can do for myself? Meditation could be one of them. Exercise could be one of them. Where are the places I go, or who are the people that could distract me, right? Like not necessarily who do I reach out to for help, but just distract me. like, is it going out to a coffee shop or a park, or there's a group or church, right? Synagogue. It could be anything that gets them out. Step 4 is, who are the people that you would talk to for help? When do you know to reach out to them? Identifying those people. And step 5 is the professionals. Like, do you have a therapist, a psychiatrist, a doctor, a case manager, a social worker, somebody, that's sort of the next step. And then 6 is environment. How do I keep myself safe? Do I have a gun? Do I have opioids? Do I have Narcan? Do I have my guns locked up? How do I keep my environment safe? The app is fantastic. It's really good. It's self-guided. I recommend you download it. Get comfortable with it. Experience it yourself. The paper plan is a great tool to do. The nice thing about the app is it's interactive. It's, it's on the person all the time. It syncs with contacts. It has a button to get you to the Veterans Crisis Line. It also, like, if self-guided meditation is something that the person does, they have meditations built into the app. They have breathing exercises built into the app. If going for a walk is one of your strategies, it will say, hey, maybe you should go for a walk, right? Like, it's a great tool. We talked about sort of financial issues briefly as a risk factor. The VA has this, it's called FinVet. It's a web page that kind of consolidates resources for veterans to get financial assistance. It's a really nice resource worth checking out. The bags and fancy pens that you have are from the VA's Rocky Mountain MyRec. So if you have a veteran in your care, and social workers in particular, who maybe has a history of suicide, maybe, they have made attempts, maybe they are have a chronic thoughts of suicide. These folks are national experts. They will help guide you. If you experience a suicide loss, we're here as a team to do some post-vention work and can help in sort of helping you guys support veterans who may have known a veteran who died, or just help you through it if it ever happens. But they do that as well. They're a really great resource. I'm always pushing our own clinicians, but you don't have to work for the VA to get access. You just have to be supporting a veteran. And so it's focused a bit on clinical stuff, but it's a really good resource. So post-vention is really about sort of like preparing. What happens if someone dies by suicide, and what can we do to support those around that, right? In recognizing that exposure to suicide is a risk in and of itself, and can be a destabilizing event for many of us. And we're happy to help walk you through that and be sort of a point for you on that, but it's good to have some strategies ahead of time, and this website kind of helps you think through it. So I said all that. This is our team. Sharon, I will send you the PowerPoint so you could share this, and it has all of our contact information on it. We are on the VA website, the New Jersey VA website, so you can find us. They even have our pictures up there. So we're easy to find. A tip I tell a lot of veterans is, if you're not sure who to call and get to, you can always call the Veterans Crisis Line, because what they do is they deal with the emergent situation. They deal with the crisis. Then they offer every caller, veteran or family member or friend, they offer every caller a referral to the local suicide prevention coordinator. That's us. So we will show up to work the next day, well, even that day. We have a dashboard, and then they send us an email, and they send us a text message and a voicemail message. So we get the information. We have that dashboard going. There's somebody looking at it right now as we're talking to follow up. So we don't deal with the crisis immediately, but we will follow up regardless of what it's about. And I can tell you, 50% of our calls are not suicidal crises. They've screwed over my benefits. Something's not right. I was talking to somebody yesterday who called because they were upset at their primary care doctor. Could be lots of different reasons. They hadn't been rescheduled with a new primary care doctor, right? So it's a way into the system that sometimes can be difficult to navigate, and we can shortcut it a little bit. All right. Any questions about VA S.A.V.E. or suicide prevention? Any thoughts about talking to someone who could be at risk for suicide? Who here has had a conversation with someone who has asked the question? I usually ask this early on. So about half of you have. Okay. Anyone feel a little more likely to ask if they see the signs? Okay.
I'm surprised when you do ask, do you feel like you might commit suicide, how open people are to answering.
Yeah. My experience is that people are often very forthcoming if they're really having thoughts of suicide. Yeah, I agree with that.
An excellent presentation. Thank you so much.
All right, thank you all. I appreciate you all coming. I'm here if anyone wants to chat for a few minutes. But thank you again.
Today we had an amazing training by Bradley Jacobs, LCSW, from the United States Department of Veterans Affairs. Bradley's knowledge and experience is committed to helping veterans that are in crisis. We learned about S.A.V.E., how to help prevent veteran suicide. Studies show that 22 to 40 veterans die a day from suicide. What can we do to help? Well, thankfully today, New Jersey Reentry had this training for our case managers and our social workers. It's very informative. There's also a list of resources that you can get by watching the video and reaching out. You can also reach out to myself, Sharon McGreevy, the Director of Veterans Services. I thank New Jersey Reentry for giving us this opportunity to help save veterans' lives. We are so grateful to our veterans. God bless them, and thank you so much.